1:1, it is +2. Starting dose was 5 milligram and titrated to test against the placebo for the mavacamten was found to be superior to placebo at improving the exercise capacity and health status. We want to go very fast through the clinical trials. We talk about them, and these are the symptoms for the inclusion criteria, statement condition which doesn't require any controls, excluded also prior SRT, and body mass index more than 25 or 55. The result, the primary composite functional endpoint was in favor of blood. And we can see that the improvement in PCO2 and the improvement in classification condition also more than
Bismillah. Mercury and 30% also less than 30 plus NIHA class improvement. This is the conclusion we talk about it. And Explorer HCM trial demonstrated efficacy of mavacamten in obstructive hypertrophic cardiomyopathy, well tolerated with safety profile, and the Explorer HCM study, a cohort group was extended. That's the long-term extension in MAVA trial. The long-term extension still it's going on the trial. It will take 5 years, and because of time, the cohort also in Explorer shows that in Explorer long-term extension shows that improvement in the gradient. Time is up. Okay. The other one was Valor HCM trial, which has this is to see if you can, if all patients who are eligible for SRT, if they started on mavacamten, will it be eligible for the SRT? And they found that they significantly reduced the eligibility for needing SRT after follow-up of 16 weeks. We will go, okay. And the long-term extension also of hypertrophic cardiomyopathy patient, and you can include the septal reduction therapy eligible patient, there were treatment on beta blocker, calcium channel blocker, and there is no, still the patient is symptomatic. The gradient should be more than 50 millimeter mercury, and don't use them if the ejection fraction less than 55.
contribute to this very high prevalence and incidence of cardiomyopathy in that area. The symptom of peripartum cardiomyopathy diagnosis of exclusion, differentiated from diastolic dysfunction in females with, for example, with hypertension, or other from preeclampsia, hypertrophic cardiomyopathy, myocarditis, valvular. We should exclude all these causes of heart failure if there is no aberrant cause of heart failure, though, so this fulfill the criteria of peripartum cardiomyopathy. Whether BMB is useful, yes, it's useful. BMB will not increase during normal pregnancy, and they said that it's very useful to diagnose a patient with peripartum cardiomyopathy by doing her BMB. There is a cut-off point of, for example, 111. This is the cut-off point. After over that, it could suggest that this patient may have peripartum cardiomyopathy. Risk factors: the Africans, African American, they have very high incidence of peripartum cardiomyopathy, preeclampsia, pre-existing hypertension, old material age, multiple gestation, multiparity, family history of DCM. They have more. It's one of the risk, and other it could be increasing the risk. There is a nice observation that, for example, this preeclampsia, there is an association between preeclampsia and peripartum cardiomyopathy. For example, this normal pregnancy, about 10% they may have preeclampsia, but in population with peripartum cardiomyopathy, about 30% of this patient, they may have preeclampsia. So there is some association between preeclampsia and peripartum cardiomyopathy. Why does it happen? Many hypotheses is there. Some people, they said that it could be a viral myocarditis, autoimmune disease, selenium deficiency, or hemodynamic stress of pregnancy. الهيموديناميك ستريس اوف بريجنسي مش ماشيه مع الموضوع. الهيموديناميك عاده during pregnancy الكاردياك اوتبوت والستروك فوليوم والهارت ريت انكريزنج في السكند تريمستر اوف بريجنسي، لكن الكارديوميوباثي نشوف فيه في الثيرد تريمستر اوف بريجنسي، فمش ماشيه الامور مع بعضها. الهيموديناميك ستريس مش ماشيه مع بتاع البيريبارتم كارديوميوباثي. ف I think this hypothesis is يعني weak. إذا كان صار cardiomyopathy في early pregnancy, this is a DCM, maybe this is a cardiomyopathy, not peripartum. لكن peripartum عادة في last trimester وفي early months of after delivery. Important hypothesis is that peripartum cardiomyopathy is a vascular disease triggered by hormonal changes of late pregnancy. This is another hypothesis. They said that the placenta excrete some substances like soluble FLAT1 and البituitary prolactin وهذين كلهم يعني both these substances could have effect on the vasculature causing endothelial dysfunction, causing cardiomyocyte apoptosis and cardiomyocyte death, and this may lead to peripartum
Can we play the video please? تعرف لو ما يخدمش الفيديو يا جماعة الاي في ماشي يخدم. Can you try and play the video please? Okay, it's playing. طبعا زمان كانوا يستخدموا في clay pot, لكن تو commercially أنا ما حيكون plastic pot, and this is what it looks like. تويجي. That's it. هذا هي التاكاتسوبو. Okay. So we have to speak the same language. There are different classifications and terminologies for Takotsubo, but according to the ESC guidelines, they try to shy away from calling it a cardiomyopathy because it's transient. So we're just going to call it TTS. So it can be called stress-induced cardiomyopathy, broken heart syndrome, apical ballooning. Apical ballooning is not a good one because there are different types of TTS. So epidemiology, it's not uncommon. It's about, in all comers of STEMI, it's about 1 to 3%. In women, it's about 5 to 6%. In all ACS presentations, it's about 2%. Now, they say that there's no clear geographical or ethnic differences, but I don't know what the audience might think. We, in the Middle East at least, have very emotional responses to certain things. For example, death in the family and so on. And we don't see I don't know about the statistics here, but I don't think we see it as often here, despite having severely emotional reactions to certain circumstances in our families or whatever. Or our brothers and sisters in Gaza, you know, with all the tragedies that they go to, do they have stress-induced cardiomyopathy or TTS or not? So I wonder whether there is a geographical and ethnic difference around the world. For example, after the flooding in Derna, I don't know if there's any statistics about any TTS or increased cases of TTS in Derna, for example. So epidemiology mostly in women, mostly postmenopausal women. However, it's been described in babies, but rare. It's not only in postmenopausal women. A lot of people have psychiatric illnesses or neurological diseases, including intracranial hemorrhage. Now there's this neurocardio axis, which we'll talk about a little later. There are different types of TTS. It's very important to remember this slide because it's not only apical ballooning. So just because you don't see the typical Takotsubo looking angiogram or echo does not mean that the patient does not have Takotsubo. So you need to look at all the walls and make sure that you assess all the walls for any wall motion abnormalities. There are many theories, none of them have stood the test of time. The most common one is catecholamine surge because of either the physical stress or the emotional stress causing a cascade of things that will eventually cause the apical ballooning. There's also this concept of negative inotropy with high concentrations. So the more catecholamines you give, the less pumping action of the heart you will get, or stunning. I don't know how true that is. We don't really see it that often in patients who are in the ICU, for example, who present with sepsis and on rocket fuel of catecholamines, yet they don't always get Takotsubo. There's this concept of regionality, thinking that the beta receptors are more prominent or found more at the apex compared to the other parts of the LV wall. But as I showed you, there are different types of Takotsubo, so that theory doesn't stand either. The brain-heart axis is thought to be an important axis, but in patients who have heart transplant it's happened as well when the heart is completely denervated. So there's no nerve connection, yet they still can get Takotsubo and has been reported. These are the triggers. I'll leave you to look at them on the slides. Will be available for anybody who wants them. But the 36% are physical triggers, about 28% are emotional. The emotional triggers are more common in women. The presentation is unfortunately non-specific compared to the ACS presentations. Most common symptom is chest pain and shortness of breath. They can have syncope as well. Troponin is not always elevated for some reason, but BNP is also elevated. There are people who try to find a ratio between BNP and troponin to try and discriminate between ACS and TTS. ECG abnormalities are not always there, but the majority of the time they will, about 80%. And sometimes you'll find bystander coronary artery disease, and that's where the oculostenotic reflex hopefully won't kick in, and they'll know that it's not the cause of the patient's presentation. Diagnostic criteria, we'll split them into primary TTS and secondary TTS. Primary TTS is when the patient presents with a cardiac symptom to the emergency room, whereas secondary TTS, the patient may already be in the hospital and has another condition, for example, intracranial bleed or stroke, and develops TTS after that. ECG abnormalities, like we said, 80%. The most common finding is ST elevation, which complicates the picture, about 44%. The second most common finding is T-wave inversion. ST depression is not always present, and left bundle branch block can occur as well. There are people who try to help distinguish between a STEMI caused by plaque rupture and a STEMI or ECG abnormalities caused by TTS, but it's not that solid criteria. As you can see, the ST elevation in V1 is more common in ACS than TTS. Biomarkers, troponin, like we said, is elevated in about 87%. They peak around about the same time, ACS and TTS, but the troponin does improve a little faster than ACS. It does not correlate with the extent of wall motion abnormalities, so there's significant wall motion abnormalities, but the troponin doesn't reflect that. BNP is also elevated, NT-BNP, pro-BNP can be also elevated. It takes a few months for it to completely resolve. These are the 5 main imaging tests that you can order to help diagnose TTS. Coronary angiogram is very, very important. Unfortunately, it's the only thing that will, for sure, give you a differential diagnosis whether it's an acute coronary syndrome or not. Most importantly, the interventional cardiologist has to do an LV-gram and has to do the gradient across the LVOT. Echocardiogram is very, very important. I made a rule here, I don't know if there's such a thing out there, but it's Osama's rule. If you have an ultrasound machine in the ER, in the emergency room, you have to use it. This is very helpful because sometimes the patients might not present right away after the event. And if they come back and the echo, for example, you see the apical ballooning or the wall motion abnormalities, you can tell the interventional cardiologist that, okay, this is the finding that we saw, so that they don't jump to any conclusions. Especially if the patient is stable, and when they are waiting for the coronary angiogram, their LV function might actually normalize within the emergency, within the hospital stay. The things to look for when you're doing the echo is the LVOT as well, and looking for RV involvement, which is not uncommon, but it's very difficult to assess on echo. Make sure you always, always, always look for an LV thrombus. Remember that in TTS, wall motion abnormalities extend beyond the distribution of a single coronary artery territory. Cardiac CT is not that helpful, except when you're not really going to do anything except diagnose the patient whether they have TTS, whether they have any significant coronary artery disease or not. These are usually patients who are in the hospital who may present with demand ischemia, and you really want to make sure that they don't have any significant coronary artery disease, but you might not want to be doing any intervention because of their poor prognosis, but just a diagnosis. Cardiac MRI is extremely helpful in situations when the echo has normalized. So the unique feature of TTS on MRI is that there's myocardial edema. There's no late gadolinium enhancement, there's no scarring. And when you repeat the MRI later on, that edema goes away and becomes completely normal. So absence of late gadolinium enhancement in dysfunctional LV regions allows distinction between TTS and other conditions, including ACS and myocarditis. Nuclear imaging, you can see that the perfusion imaging might be a little bit mild, whereas the metabolic imaging I just want to see the pointer. On the right is the, on the left is the metabolic imaging, which is not that reduced. Sorry, which is more reduced than the ischemic imaging on the right, as you can see. Whether that's of any significance, not really sure. There are many people who have tried to create tools to help diagnose and distinguish TTS from ACS. The Mayo Clinic has criteria. There's a very kind of a fancy criteria called the Intertac group, which is trying to create a registry. They have their own criteria as well. Different societies have their own criteria. Everybody's working in silos. But the Intertac diagnostic criteria actually gives a score based on these criteria, and we'll look into it in a second. So let's say, follow one of these streams. A patient comes in with a non-ST elevation myocardial infarction, because if they come with a STEMI, you're going to send them to the cath lab, so that's out of the question. The Intertac score in patients who have a non-STEMI. So if their total points are greater than 70, there's a high probability that it's TTS. So you go down on the right, you go down the protocol, you do the transthoracic echo. I have a lot more slides, but anyway, so you do a transthoracic echo. If the patient is, if it shows TTS, then the patient's stable, you go ahead and do CT angiogram. If there's coronary artery disease, you can send them for a coronary angiogram. If there's no coronary artery disease, make sure you rule out other causes. Repeat the echo. If the wall motion abnormalities persist, then you have to look for other causes of cardiomyopathy, including myocarditis or ACS. Management, unfortunately, there are no guidelines, no robust evidence. Treatment is divided into acute management and management of complications. Some countries have capabilities of treating patients in the ambulance or diverting patients from the ambulance, taking the patient from the ambulance straight to the cath lab. But in the ambulance, they can start the medication based on symptoms and ECG findings and approval by a physician to say go ahead. So there's acute management and chronic management. The chronic management, you can see question marks in all of those medications. If the patient is in cardiogenic shock, which occurs about 20%, always evaluate for the LVOT obstruction in the ER by echo or cardiac catheter if the patient goes straight to the cath lab. Acute management, beta blockers, you need to be careful, especially in patients who have prolonged QT, because you can predispose them to arrhythmias. If they're bradycardic and hypertensive, be careful. Some people say that non-selective beta blockers might be helpful. In the acute phase, again, you're going to start them on the ACE inhibitor, ARB, diuretics, and nitro, depending on their symptoms. LV thrombus must be ruled out before discharge, especially in patients who have less than 30% EF. Do not start anticoagulation prophylactically. Do not rush the patient for any device because of arrhythmias in the beginning. You can always try temporary pacing. Then you have to risk stratify the patient to low and high risk, depending on how they do and when they're going to be discharged. This is a list of potential complications. Most frequently is heart failure, LVOT obstruction, and mitral regurgitation because of systolic anterior motion of the mitral valve leaflet. Ventricular tachycardia or polymorphic VT is not uncommon. The patients do have a prolonged QT interval. The ECG that I have there at the bottom is a patient who had 7 episodes of TTS. Eventually, unfortunately, she developed this arrhythmia and she did need to have a defibrillator replaced. In shock, if the patient has no LVOT obstruction, standard therapy, but unfortunately, if we think of the mechanism that catecholamines are going to make things worse, you can actually make things worse. When there's LVOT obstruction, the most important thing is not to delay mechanical support. Don't try and fiddle around with any medication. Catecholamines are going to make things worse. There's a medication called levosimendan, which is not very popularly used anymore, but it is a calcium sensitizing medication that may buy you time if you have it. We don't have it in Canada. These are some of the predictors of poor outcome: male, neurological involvement, and EF of less than 45%. This is the most depressing slide. Nothing is really effective. Beta blockers, no. Statins, no. ACE inhibitors, no. ARBs, no. Aspirin, no. So long-term management focus on the risk factors of any concomitant condition. So you can have coronary artery disease, you can have LV dysfunction, you just need to treat that. ACE inhibitors, ARBs are the only things that have maybe shown to prevent recurrence, but this requires validation. This is a summary of treatments. I'll leave it in the slide. We'll keep moving. In-hospital mortality is 5.6%. It's not trivial. MACE is 10%. It's not trivial. But we don't really have good long-term data for survival, but it's not a benign condition. Just look on the right side. There's no significant difference in survival between patients who have coronary artery disease and TTS. If you improve your LV function early on, your prognosis is very good. If you don't, then your mortality is higher. If you present with shortness of breath, your mortality is higher. Recurrence is about, depending on where you read, 5 to 22% within 3 to 10 years. It can happen with different triggers. So you may have an emotional trigger one time, a physical trigger one time. There are some suggestions of what to do to prevent recurrence. Meditation. We say, we'll call it exercise, group therapy. Antidepressants have not been shown to be helpful. These are resources for patients who might want to go and check out these websites. There are 3 ongoing trials looking at potential improvements, diagnosis and treatment. Unfortunately, there's no prospects ahead so far. So it's not uncommon, it's very serious, it's a challenging diagnosis. You need to be careful, but you only see it if you look for it. So at the end of the day, the majority of the patients are going to improve. So 95% of patients will get better. So use your judgment, because there's no real good guidelines. Try to err on the side of being conservative. The patient that we saw had a CT scan of the chest because of her symptoms to rule out dissection and PE. Now, some facilities have a triple rule out. We didn't. But sent for a cath which showed a 50% LAD lesion, which was left alone. She had the akinetic mid-LV walls. Echo confirmed that. She was discharged home after 3 days on metoprolol, ramipril, aspirin, and her other regular medication. Sent to cardiac rehab. Repeat echo in 3 months, was completely normal. Thank you very much.
Thank you, Osama. It's really, really fantastic. I've learned a lot from this talk. It's my pleasure now to introduce our last but not least speaker, Dr. Salah Elbadri. He's a consultant cardiologist and advanced heart failure in Mohamed Medical Center in Qatar. I knew Salah for the last 2 or 3 years. He's a fantastic, humble guy, excellent speaker. I've learned a lot from his previous talk that I attended. We gave him a really challenging talk on cardio-oncology guidelines. Floor is yours, Salah.
Assalamu alaikum. Rahmatullahi wa barakatuh. Esteemed Chairman, my colleagues, it's a great pleasure and honor to be with you today. I don't have a disclosure except that I'm not cardio-oncologist. Dr. Harari and Dr. Abdou gave me this topic, which is of critical importance, as it's a critical need for our patients. These are my objectives. You can read them. We'll end up with presenting one case. Should we be disappointed that we don't have cardio-oncology? Actually, we should not be disappointed because the very first guidelines of cardio-oncology was just in 2022. This is the first. That means we have to catch up. Just 2 years. If we start the service now, everything will be like, we'll catch up on the other part of the world. The guidelines were started from a blank page. Let's start with a clinical case. 64 male diagnosed with diffuse large cell lymphoma. He received R-CHOP, this combination of therapy, including one of the anthracycline. He has no significant symptoms, mild general fatigue, no other symptoms. ECG is normal. Troponin was 41 and proBNP 130. So pre-therapy was within normal, and there's a rise in troponin and proBNP. Ejection fraction is 51. Pre-therapy was 62. GLS, the global longitudinal strain, this is a deformation imaging. We're using speckle tracking, and it can detect early systolic dysfunction. So before was normal, and now is minus 16. So what do you think? How do you define his cancer therapy-related cardiac dysfunction? Is it mild symptomatic cancer therapy-related cardiac dysfunction? Is it mild asymptomatic CTR-CD? Is it moderate asymptomatic or severe asymptomatic? Just think about it, and we'll come back to this case. So the guidelines adopted personalized approach based upon baseline cardiovascular toxicity, new protocols for cardiovascular surveillance, management of acute and subacute events during anti-cancer therapy, and they emphasized on the first 12 months after completion. So the problem is not during only, even after, the first year after chemotherapy. And then beyond this, you have to predict a long-term cardiovascular complication after the oncology treatment finished. And this is the dynamic of the risk. You see, a low-risk patient will have, during therapy, an increase and cardiotoxicity cancer therapy risk. The higher case or the higher risk case will have a higher risk. It will get worse with the therapy, and the cardio-oncology strategy is to intervene very early. So either with primary or secondary prevention strategy. We can give treatment for traditional risk factors or for cardiovascular death. And then during therapy, we need to intervene very early. And the first year after completion is very important. And we have to predict which patient with cancer survival should be followed. So the risk stratification is very important. This is the job of oncologists, and actually we should build a cardio-oncology team involving cardiology and oncology, but this part is by oncology. The HFA ECOS baseline risk tool can be downloaded for free from the European Society of Cardiology website. Will classify patients as low risk, moderate risk, or high, very high risk. It's simply involving clinical assessment, cardiovascular history, examination, traditional risk factors, echo and cardiac biomarkers, and these factors which highlighted on the right. And then we classify patient low, less than 2%, medium, high, and very high, more than 20%. And after that, the oncologist, this is still the work of oncology, if he is a low risk or the patient is low risk, routine oncology follow-up, and if he developed cardiovascular toxicity, he will be referred. And now if he's moderate, then a closer oncology follow-up. And if he is very high, then immediate referral to the cardiology and discussion as MDT. It's very important to communicate the results of this test to the patient and the team. And it is, between frequency and severity. Some risks are like mild, but very frequent. For example, hypertension can be highly likelihood in some chemotherapy, but with mild severity. And some cardiovascular or cancer therapy-related cardiovascular toxicity, like myocarditis, low in likelihood, but with severe and very severe consequences. Imaging, echo is important. 3D, if available, will be much better, and GLS is recommended. So the 3 is a class 1 recommendation. If the echo is not diagnostic, some cancer patient will have like surgery, radiotherapy, and then we need to have the MRI if the echo is not diagnostic. But the class 1 is transthoracic echocardiography, which is widely available. And every single patient should have echocardiography if he is a high or very high risk. So I'll not be able to cover everything. We selected some of these cancer-related cardiovascular toxicity. And this is, for me, this is the most important slide. See how we define the cancer therapy-related cardiac dysfunction. Either symptomatic or asymptomatic. See, if the patient requires ICU admission, and we are thinking of mechanical support, and this is very severe. And if the patient requires heart failure hospitalization, this is severe. If he's outpatient and you are intensifying treatment, then this is moderate. And if he's just mild heart failure, this is mild. Now for asymptomatic, now we have the ejection fraction here in asymptomatic. We'll start from the mild is preserved more than 50. So in addition to that, we have either the reduction of the GLS by more than 15% or a rise in cardiac biomarker. Moderate, if we have a reduction of 10% and the ejection fraction between 40 and 49, that's it. We didn't need the GLS here or biomarkers. And if it is less than 10%, then we need the GLS and biomarker. GLS less, more than 15% and any rise of cardiac biomarkers. Severe is ejection fraction below 40. You know, in heart failure, we have severe if it is less than 30%. A new reduction, 40% is severe asymptomatic CTRCD. Well, back to our case. You see, we have an increase in troponin. We have increase in pro-BNP. Ejection fraction dropped, but still above 50. GLS is more than 15%. So it is in this category. Mild asymptomatic CTRCD. We'll select some of the chemotherapy related cardiovascular toxicity. The immune checkpoint inhibitors used in small cell carcinoma, some sarcomas and others. It can cause direct and indirect, but the most important one is myocarditis. It's rare but fatal. 50% of patients, if we didn't detect them, they will die. So, and you know, in these patients, we are thinking that they are deteriorating because of the cancer, while they are deteriorating of something else. So we have to think if the patient taken immunotherapy checkpoint inhibitors and he suddenly deteriorate, we have to check his troponin. If the troponin increased, we need one major criteria, which is MRI, if available. If not, we use two minor criteria as listed here. But it's very important to diagnose myocarditis in patients with such therapy. So it could be fulminant. That patient will die not because of cancer, will die because of acute fulminant myocarditis. And we have vascular toxicity, many of them asymptomatic, but we can get acute coronary syndrome. The cancer is very thrombogenic condition, and we have some chemotherapy which can cause acute coronary syndrome, listed here. The QT interval is very important. We have to, and we have the cutoff more than 500, where we have to think of alternatives. The atrial fibrillation is very frequent, and along with other factors in usual atrial fibrillation patient who might have anti-cancer treatment, cancer surgery, and others. How to manage? So remember the definition. We'll take the symptomatic and asymptomatic. If the patient is symptomatic, for example, this is the most serious condition, the anthracycline CT-RCD, and it's said to be irreversible. But look, if the patient is mild, we have to have an MDT with the oncology to see whether to continue or to interrupt. If it is moderate, we have to interrupt. Severe or very severe, discontinue. And if it is mild, and you remember the definition, what's mild? Mild, we have to continue, but we have to look for increase in pro-BNP and our GLS, and we start heart failure therapy. You should not discontinue if it is just mild. And we interrupt if it's severe or moderate asymptomatic CRTD. The other one is very frequent, is the Herceptin, HER2 CRTD. And if it is symptomatic, again, if it is mild, then we have to have MDT. If it is moderate to severe, we have to interrupt. Now, for asymptomatic, we have to continue if it is mild, and it's class 2A if it's moderate, and if it's severe, we have to interrupt. The myocarditis should be treated as you know, for severe myocarditis. So we use pulse therapy for 3 days, 500 to 1,000, and we are looking for either recovery or refractory give second line. That's turbulent speed because of the time constraint. For venous thrombosis, we have to use this TBI-B, T for thrombosis, B for bleeding risk, I for interaction, and P for patient preference. And if the patient very high bleeding risk, no anticoagulation, low molecular weight heparin is favorable. And if the patient can take NOAC. So NOAC cannot be given in gastrointestinal or genitourinary cancer. Full stop. This is a contraindication. We have to use low molecular weight heparin. Other cancers, the patient preference. If he prefer NOAC, we can give it. Okay, for acute coronary syndrome, patient with cancer can present with STEMI. So he should not be like, saying that it's cancer, will not do anything. We look for life expectancy. If it is more than 6 months and the patient has a good survival, then we have to treat him as any other patients. And it is class 2A to treat conservatively. And aspirin should not be given if the platelets less than 10,000, clopidogrel less than 30, and prasugrel and ticagrelor less than 50%. QT more than 500, you should avoid and interrupt. If it is 480, 500, alternatives considered. And we have to look for any other cause, Sometimes we have other cause, drug or electrolyte. Atrial fibrillation, we use the same TBI-P, and if it's a high risk, then no anticoagulation, we use LLA, left atrial appendage occlusion as a class 2B, and if it is, moderate and severe mitral stenosis, rheumatic, or mechanical valve. This is the only use of VKA, and if it is not, then we use either low molecular weight or NOAC unless there is contraindication. Okay, this is the last, this is the case. 72 female with diabetes, hypertension, dilated cardiomyopathy, CA breast, invasive lobular carcinoma. She has her receptors positive, and she has no metastasis. So this is the tool which can be downloaded for free, and this is the link. We just applied for Herceptin, and then we can detect the risk. And in this case, is a high risk for cardiotoxicity. So the patient and her daughter was informed and benefit of anti-HER2-based chemotherapy, and they were informed about the toxicity. Oncologist suggested this treatment, including trastuzumab, which is Herceptin, for 17 cycles, and condition pending cardiology. Remember, this patient had mild dilated cardiomyopathy, but she was not under any treatment. She was referred to cardiology, and this is her baseline LV function, around 50%. And global longitudinal strain 17.6. Okay, so after 3 months, as usually doing surveillance after 3 months, this is her ejection fraction. So how do you define her CTRC function? This is the global longitudinal strain. What do you think? Severe, right? Because patient has no symptoms, less than 40, so it is severe asymptomatic CTRCD. And what we have to do? So it is severe asymptomatic interrupt. So it was interrupted for 4 weeks. Patient received bisoprolol and valsartan. Echo report repeated. Ejection fraction is back to baseline. And this is my key take messages. So early cardiovascular risk evaluation by oncology, hematology is vital. Managing cardiac function is crucial. Use target imaging and biomarkers. And we have to build a cardio-oncology team. Thank you so much.
Thank you very much, Dr. Elbadri. That was fantastic 4 talks that were, extremely well designed, and I appreciate all the speakers for their contribution. And at this point, before we go into the questions, I really cannot let this pass without acknowledging my co-chair, Dr. Mohamed El-Harari, who worked tirelessly on putting this curriculum for this meeting. And, very, very dedicated work, and I really thank you very much for your contribution. Thank you. Hopefully in subsequent meetings, inshallah, what we will do is you will see these thematic or themes, the recurrence in the heart failure group, inshallah, that we will try to address them at. This year we try to make it kind of advanced heart failure light kind of thing. Hopefully in subsequent meetings, hopefully subsequent meetings we won't have these AV difficulties too. But anyways, subsequent meetings we'll try to introduce to the society the advanced heart failure. Try to introduce you guys to the advanced heart failure realm. And take you through the journey of advanced technologies and so on and so forth, from more advanced cardiogenic shock management to LVAD, durable LVADs, temporary LVADs, all the way to heart transplantation. So exciting things are happening, and hopefully we will get there. At this point, I think I will invite our speakers up to the stage, and we'll open the stage for questions.
Assalamu alaikum. Excellent talks, guys. Well done, mashallah. And thanks for the moderators. I put comment
Yes.
Okay, salam alaikum. The put comments.
واحد
Dr. Ali, Dr. Mustafa, I saw a combined case. I had a pregnant lady, 36, who came with severe heart failure, and found her to have a HOCM. First pregnancy, she's 28. That's her first pregnancy, first presentation, first diagnosis, admitted to CCU with cardiogenic shock. So the question here and the point to the audience is to act quickly, because this patient will die otherwise. We have to remember in pregnancy, we are dealing with two patients, not one patient. Just to make it short, that patient, thankfully we saw her quickly, we did an echo, diagnosis was confirmed, and we spoke to the obstetrician that that patient has to be delivered, and delivered immediately. Otherwise, we'll lose the patient and the baby. So that patient went within a few hours to the OR and had C-section and delivered a very healthy baby, and she did very well, actually. Within 2 weeks, we implanted an ICD. I followed her for the last 6 months, and she's been doing very well. So just we need to make sure that we do things quickly so we don't lose the baby and the patient. And thank you, Dr. Ali. Any comments? And Dr. Mustafa?
Yes, sure, Dr. Abdul Ghani. It's very important. المسج فور gynecologists لأن هم أكثر واحدين يشوفوا في البيشنتس هذوما. يفترض أن أي patient complaining of dyspnea and for example leg swelling or orthopnea or something like that, at least they should send her to physician. As quickly as possible. ولكن في فرق بين maybe the patient متاعك is a patient of DCM, cardiomyopathy, and she came she deteriorated during pregnancy. وهذه تختلف شوية على البيريبارتوم كارديوميوباثي اللي تصير في الثيرد
her F down was down 37%.
37. Yeah. I think this is a peripartum cardiomyopathy. A disaster فعلا إذا كان we delayed المانجمنت نتاعها ولا الدياجنوز نتاعها. nobody's مشكلة other sides just concentrate على الفيتس وعلى اليوترس على التراساوند. لكن everything is okay, so nobody even putting the stethoscope on her chest to listen to her heart. ففي مشاكل عندنا مع الجراحين ومع الجينيكولوجيست. they're not taking the patient as a package, they're just taking their
So last comment, which is, I totally agree with you, Dr. Ali. The point here is we have to push and push, because I kept calling. I called maybe 4 times for they won't take it initially. Then deteriorated. She was about to be intubated, and we said, you have to take her. You lose the patient and the baby. And you pushed. So otherwise, if you don't push, they will not take it. So we have to step in as a cardiologist to say, you will lose the baby and the patient if you don't do things quickly.
Our patient here, we lost 2 girls, a full-term girls. They just died in the last week of pregnancy.
شكرا للمحاضرات الرائعة. الحقيقة أنا عندي سؤال لكل شخص من المحاضرين. أول حاجة شكرا أستاذ دكتور مصطفى، هل في مرضى في ليبيا ياخذوا في المافا كابتن ولا الاكسبنسيف دراجز؟ هل عندك مرضى يتابعوا معك ياخذوا في الدراجز هذه؟ هل هي افيلبل في ليبيا؟
لا، في in Libya here still is not used. All the cardiomyosin inhibitors are not used. Actually, in some centers in the world, they start using them, and they have a good result in the clinical, because the clinical trials is something, and the real life is something else. And I look at the experience of some centers. Okay, one of them is the Emory. The Emory University, the hospital, they have treated many cases, and this William Robinson, I ask permission, he treated many patients and he had good result. But these patients, they should be treated according to the RIMS program. This RIMS program will include multi-dispensary. There should be a specialist cardiovascular pharmacologist, okay? And there should be cardiologist. There should be a trained nurse, special nurse, and the clinician also. And they will make special clinic to treat this patient, and they will follow up them regular. And according to the result of the echo and the ejection fraction, either you will increase or you will decrease the dose. And this really needs, it's a teamwork. It's not somebody who will come a cardiologist and they will say, I will start treatment. No. This even they need a special pharmacy. Not anybody can give this treatment. And maybe this, you know, the coming area now, the era, it will be very, very interesting, and it will be interesting to specialize in hypertrophic cardiomyopathy treatment. You are going to save a lot of patients. They are dying now, young. They can't go for SRT. Need specialized, even in America and like that, 10% of the cases get benefit of this. Need special trained special centers. And maybe through the European Society, the Libyan Society of Cardiology, we can discuss this problem and how to organize really a cardiac hypertrophic cardiomyopathy clinic.
Okay. دكتور علي بعد اذنك، هل في رول للستريس ايكو في البيشنتس اللي ظل عندهم previous history Peripartum Cardiomyopathy and they won't ask to be pregnant again؟ هل في حاجه في الجايد لاينز والله في الليترشر about ان زمان كنا we ask them to do stress echo، اذا كان they are very good with the stress echo we give them permission to get pregnant، نحكي على postpartum cardiomyopathy.
الريكومنديشن الموجوده تو ما فيش هذاك الايفيدنس بيزد ريكومنديشنز، يعني جينا يعني البوبوليشن والانسيدنس سمول، يعني دائما الجروبز بتاع البيربارتم كارdiomyopathy اللي يجروا عليهم في دراسات سمول. الريكومنديشن اللي تو اكوردنج للايجكشن فراكشن بتاع البيشنت بتاعك، اذا كان نورماليز ايجكشن فراكشن هذول عندهم لو مورتاليتي ريت ولو انترايتونال فيتال ديث ولو كومبليكيشنز، اذا كان الايجكشن فراكشن بتاعهم فات ال 50% يعني before getting pregnancy. هذه some school is saying like that، لكن some school is saying حتى improving و completely improved ejection fraction the patient should not become pregnant again، لأن في high risk of complication و maternal death و intraterminal fetal death even if normalized. لكن بعض it's very difficult I mean to recommend whether to become pregnant or not، لكن هي important for the family يعني very difficult to say to woman that you cannot become pregnant again. فهي النقطة أن فيه لازم يعني sharing decision between الدكتور والفاميلي بتاع البيشنت والبيشنت هيرسل، لكن ما فيش في الريكومنديشن ستريس تيست، هذه مش موجودة في الاستادي اللي طلعنا عليها.
Very short question للدكتور أسامة القصبي. We missed a lot of cases بتاع stress cardiomyopathy في الاي سي يو. A lot of patients خشوا في transient shock because of stress cardiomyopathy. No role of beta blockers, ACE inhibitors, as you mentioned. So how you treat these patients?
So patients who are in shock, or which kind of patients that you said, how do you treat them? العلاج والدعاء. If their ejection fraction is normal, which like I said, is usually normalizes about 95%, so alhamdulillah, the majority of them will improve. In those who continue to have a low ejection fraction, you treat them as if they have heart failure. So they stay on beta blockers, they stay on ACE inhibitors, they stay on ARNI, they stay on SGLT2 inhibitors. And if it improves. It's difficult. The difficulty is, do you stop it after they improve? So they tell us when to stop in patients who have TTS. But if you think that their cardiomyopathy, you have to use your judgment, is going to come back, they stay on it. Otherwise, there's no clear guidelines on what to do. Like I mentioned in the last statement, you have to use your own judgment, case-by-case basis, and nobody can fault you as long as you try and do what you think is right. Yeah. There's a...
That's it.
There's a little caveat, Doctor, because we think that the mechanism is hypercontractility in some parts and no contractility in others. If we know that the hypercontractility part, if you put them on pressors, theoretically that's going to get worse. Okay, so again, if they have LVOT obstruction, so these patients should not be given diuretics, for example, because it might make things worse. Not given pressors because it might make the obstruction worse. It's a very complicated condition. And in terms of, that's why I said people should not mess around with it when they're in shock, because they can deteriorate. And going to mechanical support early is very important. In fact, the majority of recommendations are to go for an LVAD or ECMO and avoid aortic balloon pump for some reason. Because there are some studies that say they might actually make it worse.
Dr. Salah, thank you for nice presentation. Thank you for your nice presentation. We had patient 47 years old, had an STEMI anterior MI, and he is unlucky. We found hemoglobin 7. Patient workup done, and we found he had CA colon. So for us as BCI, it's difficult because he will take blood thinners. Next step, what do you think? He's young, CA colon. What do you think? Question of bleeding. You will take him for chemotherapy. It's a question for all, for invasive and for you as a team.
Yeah. So this is an excellent question, and this is the purpose of my presentation. This cannot be answered by cardiology only. You know, the chemotherapy, the patients assume that he passed as non-STEMI, right? And he's now stable, right?
Yeah.
He's not an acute STEMI.
He's acute STEMI.
He's acute STEMI.
STEMI until and difficult to push him to lab because of blood thinners.
Yeah.
He should take. We found hemoglobin 7. We work up for this endoscopy upper lower, and found he had PA colon. He's young, so 47 years.
Yeah.
It's a multi-center team. It's a team, but we start first. What do you think?
So if he's acute, we'll go as any other patient. The survival is more than 6 months. If he is in a chronic phase, then he should receive the usual treatment, including beta blockers and others. And we have to consider antiplatelet according to the counts which we showed. And this case, regarding the chemotherapy, should be MDT. Which one we start? It should be agreement with the cardiologist, the surveillance after that. When we have to repeat the echo, when we have to stop this medicine or that medicine. It's not a cardiology one-man show. It should be combined team.
Yeah, we'll take the last question, and because we're running out of time, so this will be the last question. And Dr. Adil has Adil, do you have a question? And then we will close the session, inshallah. Here. Yeah.
Assalamu alaikum. Thanks for these very enlightening, very nice lectures. I learned a lot. For Dr. Zaririk, I think my interest is more for the cardiomyopathies, the HOCM part. So I think for me, when I start joining the valve clinic, increasingly we start seeing more and more of these septal hypertrophy. I think I heard yesterday the talks about TAVR. I think we will see lots of patients coming from those high quality CTs to start having the discussion about how we manage those patients who had severe ASs and basal septal hypertrophy. So I think it would be nice for us to have a dedicated team, as Dr. Zaririk mentioned. I think there should be a team, should be a dedicated surgeon, because this is a very complicated, delicate operation to be done. You won't expect any cardiac surgeon to do this with a good outcome. My question, do we have in Libya a septal alcohol ablation service? Because some patients, especially in high-risk TAVR, they may not tolerate, they may not get the surgery to address both. And some cases I've been involved, they have to treat them with septal alcohol ablation, then go for TAVR. Because if you do TAVR for a septal hypertrophy, you'll kill the patient.
What I know, any intervention regarding the hypertrophic cardiomyopathy as far as that doing this. I know nobody is doing. And we find difficulty here before. Maybe I'm retired now, I don't see this patient. But, so, we don't have, we must, and you must refer him to specialized center, and this is an easy procedure as well, as far as I know, because you have to target a special coronary branch and special place. Maybe you have not required. Yeah. Yes.
So that's. Yeah, so that's a...
But the idea
with AS. With AS. With severe AS.
Yeah.
We will take this discussion further. At this point, we have an announcement. So thank you everybody. We will close the session. We have an announcement to make, so please let's pay attention. We will have this last announcement, very important one, and we will go for a break after that, inshallah.
Assalamu alaikum. Ladies and gentlemen, one of the great things that the Libyan Cardio Society have been doing for the last few years, along with getting us together, is recognizing the people who contributed to the medical field and the cardiology field. And we saw yesterday the awards being given to the right people. Among those who, a person who was not present there is Dr. Abdou, whom you all probably know. He's
He is a great friend of mine, and I knew him for donkey's years. And he's the hardest working cardiologist I've ever seen. He's been loved by all his patients, by his colleagues, by his students. He's on call 24 hours. He does the work that people don't want to do. He's been awarded the Life Achievement Award that he very well deserved. His career has been interrupted, but not stopped by his accident. Till now, he actually follows the latest in cardiology, and he involves in all the discussion among whether direct one-to-one or among groups. I'm sure he'll be touched by this, but no one else deserves such an award like him.
Thanks for the extra time. Of course. Shukran ليك.
مش بنينا والله